Section 1, Lower Extremity Reconstruction. All right, picture this for case 1. You've got a patient with a grade 3B open tibial fracture after an accident, leaving the upper third of the tibia and the fixation plate completely exposed. The absolute best move here is the medial gastrocnemius muscle flap. Why? Because it's the gold standard for proximal tibia and knee defects. It gives you a fantastic arc of rotation to cover that exposed bone and hardware, all while bringing in robust, healthy vascular tissue to fight off infection. Other local flaps just don't have the utility for this specific zone. So lock in your very first exam pearl. Upper tibia equals gastrocnemius.
Moving right down the leg to case 2. Following the excision of chronic osteomyelitis, the middle third of the tibia is now exposed. For this one, you want to reach for the soleus flap. The clinical reasoning here is actually super specific. The soleus easily reaches that middle third of the leg, but crucially, it simultaneously preserves adequate plantar flexion for the patient. Don't overcomplicate it. Your exam pearl, middle tibia equals soleus. So what about case 3? Now our patient has exposed bone over the distal third of the tibia. Your best reconstruction choice immediately becomes the anterolateral thigh, or ALT, free flap. The logic is purely structural here. Local muscle flaps, like the gastrocnemius or the soleus we just talked about, literally cannot physically reach that far down to the distal tibia. That physiological limitation dictates our next pearl. Lower third leg equals a free flap, like the ALT or reverse Searle.
Okay, case 4 introduces a hardware complication. We've got wound breakdown after a total knee replacement, and the prosthesis is exposed. The go-to flap is, once again, the medial gastrocnemius. An exposed artificial implant demands a bulky, highly vascularized muscle to completely bury it and control any brewing infection. You need to make this an automatic reflex in your mind. Pearl, knee implant exposure equals gastrocnemius.
Wrapping up the lower extremity with case 5. A sequestrectomy for proximal tibial osteomyelitis leaves a massive dead space. We're going right back to the gastrocnemius. You absolutely must have a muscle to obliterate that dead space. Filling it up drastically improves the delivery of systemic antibiotics directly to that site of chronic infection. This is a crucial pearl. Dead space plus infection equals a muscle flap.
No breaks, let's hit section 2, head and neck reconstruction flaps. Case 6. After excising a basal cell carcinoma right on the nasal tip, a 2-centimeter defect remains. Your selection should immediately be the paramedian forehead flap. The reason for this is purely aesthetic, but it is heavily tested. It is the absolute gold standard for large nasal defects because it gives you an unmatched color and texture match to the native nasal skin. Memorize this pearl. Large nasal defect equals forehead flap. Case 7 deals with a hemimandibulectomy for oral squamous cell carcinoma. The ideal flap here is the fibula osteocutaneous free flap. Think about it. Replacing the jaw requires vascularized bone for rigid structure, plus a skin paddle to recreate the intraoral lining. The fibula provides both of those beautifully in one neat package. High-yield pearl, mandible equals fibula. Following a hemiglossectomy in case 8, we need reconstruction. The preferred flap is the radial forearm free flap. The tongue demands highly specialized tissue, right? Well, the radial forearm provides incredibly thin, pliable tissue that is essential for preserving the tongue's mobility for speech and swallowing. Lock in the pearl. Tongue equals radial forearm, or alternatively, the ALT. Now, case 9 throws us a strict clinical constraint. A patient has a buccal defect following cancer excision, but they absolutely cannot undergo microsurgery. The best regional flap in this scenario is the pectoralis major myocutaneous, or PMMC. It's a remarkably reliable pedicled flap that easily reaches up into the oral cavity without any need for complex microvascular anastomosis. So your constraint-driven pearl, head and neck plus no microsurgery equals PMMC. For case 10, following trauma, an 8-centimeter scalp defect with an exposed calvarium remains. The answer here is the rotation scalp flap. The core surgical rule in play here is replace like with like. This flap provides similar, hair-bearing tissue while utilizing the scalp's amazing natural blood supply to ensure viability right over that bare bone. Pearl, scalp equals rotation flap. Finishing up the head and neck, case 11 features a massive defect where more than 2/3 of the lower lip is excised. You must select the Karpathyk flap. This flap is frankly ingenious. It brilliantly preserves the neurovascular bundles, which maintains both motor function and sensation to the newly formed lip. Pearl to remember, large lower lip defect equals Karpathyk. Shifting gears, section 3, trunk and breast reconstruction flaps. In case 12, a woman requests autologous breast reconstruction following a mastectomy. The preferred choice today is the DIEP flap. This entire decision is all about minimizing donor site morbidity. Unlike some of the older techniques, the DIEP flap carefully preserves the rectus abdominis muscle while still giving you abundant skin and fat to create a natural-feeling breast. Pearl, modern gold standard, equals DIEP.
Case 13 presents a classic, really high-stakes scenario: mediastinitis with sternal wound dehiscence after a CABG. The absolute best choice is the pectoralis major flap. This goes right back to our earlier rule about dead space and infection. You need to bring a robust vascular muscle directly into that infected mediastinum to fill the space and fight the infection head-on. Pearl, sternal wound after CABG equals pectoralis major flap.
Section 4, Rapid Revision. Let's lock this knowledge in permanently with a relentless, rapid-fire final drill. No hesitation on these.
Lightning round time. Process this as fast as humanly possible. Upper tibia is gastrocnemius. Middle tibia is soleus. Lower tibia is ASLT or reverse Searle. Knee prosthesis is gastrocnemius. Osteomyelitis dead space is gastrocnemius. Large nose defect is forehead flap. Mandible is fibula free flap. Tongue is radial forearm. Buccal defect with no microsurgery is PM&C. Scalp is rotation flap. Large lower lip with carapan zig. Breast reconstruction is DAEP. And an infected sternum is the pectoralis major.
All right, Section 1, Trunk and Pelvic Defects, where we're addressing massive anatomical deficits.
Okay, let's look at case 14. Imagine you've got a 58-year-old guy who just had an APR, an extralevator abdominal perineal resection for low rectal cancer. Crucially, he has an irradiated pelvis, and the surgery leaves a massive perineal cavity. So what's your best flap? Well, you have to bypass options like the gluteus or gracilis and immediately choose the VRAM flap, the vertical rectus abdominis myocutaneous flap. Why? Because an irradiated pelvis is a highly hostile, poorly vascularized environment. The VRAM brings robust, healthy, non-irradiated tissue down from the abdomen. It totally obliterates that dead space, preventing fluid accumulation, wound breakdown, and that dreaded perineal herniation.
Listen, this specific equation is absolutely high yield. You literally need to hardwire this into your brain right now. Whenever you see an APR combined with an irradiated pelvis in a question stem, the answer is always the VRAM flap.
Moving right along to case 15, following the resection of a chest wall sarcoma involving the ribs, your patient is left with a massive posterior chest wall defect. Now, your brain might automatically jump to a PMMC or a DIEP flap, but actually, the undisputed definitive choice here is the latissimus dorsi myocutaneous flap. Why is that? Well, because the latissimus dorsi is the largest pedicled muscle flap in the human body. It gives you absolutely unparalleled reach and immense volume to safely cover exposed vital organs and hardware in the chest. So remember this pearl: massive chest wall defect equals latissimus dorsi.
All right, let's transition into something you'll see all the time: the classic pressure sword triad. Case 16 gives us a paraplegic patient with a grade 4 sacral pressure ulcer and exposed bone. An exposed sacrum demands thick, reliable, and incredibly durable coverage to withstand any future pressure. And that makes the gluteus maximus flap your definitive answer over much thinner options like the sartorius or gracilis. It's perfectly positioned geographically, and it provides that vital padding. Your exam pearl here: sacrum equals gluteus maximus.
Now, check out case 17. Conversely, if the stem presents a deep ischial cavity in a wheelchair-bound patient, the dynamics totally change. The ischium creates this deep, narrow cavity rather than a broad, flat defect. The gracilis flap is the perfect biological solution for this. It can be easily detached and folded in on itself to tightly pack and fill that deep ischial dead space. Plus, it comes with wonderfully minimal donor site morbidity. Lock this pearl in. Ischium equals gracilis.
And to complete our pressure sore triad, case 18, we have a patient with a deep ulcer directly over the greater trochanter. A trochanter defect requires a flap that can stretch over the lateral hip joint and provide really robust structural support. This requires the strong fascia and the perfect geographic reach of the tensor fascia lata, or TFL flap. So for your exams, just remember the triad. Sacrum gets the gluteus, ischium gets the gracilis, and the trochanter gets the TFL.
Okay, moving on to Section 2, Extremity and Hand Reconstruction. Here, it's all about preserving function and sensation.
Take a look at case 19, A carpenter comes in with a fingertip amputation and an exposed distal phalanx. You might be tempted to use a cross-finger flap here, but for a small fingertip amputation with exposed bone, you really must choose the VY advancement flap. The reasoning here is just beautifully elegant. The VY flap uses local sensate tissue from the exact same digit and slides it forward. This critically maintains both the finger's length, which is obviously vital for a carpenter, and its native sensation. Small fingertip equals VY.
But wait, case 20 presents a slight variation that changes literally everything. A 1.5 centimeter defect specifically on the thumb pulp with exposed bone. You know, the thumb is responsible for 50% of hand function, and its volar sensation is absolutely non-negotiable. Here, the Moberg advancement flap is uniquely superior. The Moberg specifically advances the entire sensate volar skin of the thumb as a single unit without compromising the dorsal blood supply. When you see the words thumb pulp, immediately think Moberg flap.
Now, case 21 involves a deep laceration where the flexor tendon is completely bare, meaning no paratendon. A bare tendon just cannot support a simple skin graft. It will simply die. It desperately needs its own independent blood supply. And this makes the cross-finger flap the undeniable correct answer. You essentially borrow healthy, vascularized skin and subcutaneous tissue from the adjacent healthy finger to drape over the bare tendon. This ensures its survival and allows it to glide smoothly. Bare tendon equals cross-finger flap.
Shifting gears to burn reconstruction in case 22. We've got a child with a linear post-burn contracture right across the popliteal fossa, and it's severely restricting their knee extension. A simple skin graft won't fix the mechanics here. A 60-degree Z-plasty is the mathematical and biological winner. By transposing two triangular flaps, you magically yield a massive 75% gain in the tissue's length, all while completely redirecting the tension lines of the scar away from the joint axis. It's brilliant.
Section 3. Complex vessel and facial defects. Navigating high-stakes anatomy. So, in case 23, an inguinal lymph node dissection guy's a bit too deep, leaving those critical femoral vessels totally exposed. You obviously can't leave major vessels bare because of the catastrophic risk of blowout. The most elegant direct solution? A simple sartorius muscle transposition. You detach the sartorius from its origin on the anterior superior iliac spine and literally just swing it over to blanket the femoral vessels. It's quick, it's local, and it's highly effective. Exposed groin vessels perfectly pair with the sartorius flap.
Case 24 is a super critical one. A woman previously treated with radiotherapy for breast cancer develops axillary radionecrosis with an exposed axillary artery. Just like we saw on the chest wall earlier, an irradiated axillary ulcer is a necrotic, ticking time bomb. You have to forcefully import healthy, well-vascularized tissue from outside that zone of injury. The latissimus dorsi flap is the undisputed champion here. It easily rotates right into the axilla to provide thick, healthy coverage over that artery.
And case 25 takes us to the face. After a basal cell carcinoma excision, the patient is missing over 50% of their lower eyelid. You can't just pull that closed, right? For massive lower eyelid defects exceeding 50%, the Mustedy cheek rotation flap is a true reconstructive masterpiece. It brilliantly pulls adjacent cheek skin up to reconstruct the anterior lamella while leaving room for a mucosal graft on its underside to replace the posterior lamella at the exact same time. Massive lower eyelid defect equals the Mustedy flap.
Take a breath, because here's Section 4, the Rapid Flap Revision Guide. This is your total diagnostic matrix.
Here it is. This is the ultimate cheat sheet, mapping clinical problems directly to their surgical solutions. From the VRAM for that APR perineal defect to the latissimus dorsi for the chest wall. Remember your pressure sore triad. Sacrum is gluteus maximus, ischium is gracilis, and trochanter is TFL. For the hand, VY for the fingertip, Moberg for the thumb pulp, and crossfinger for the bare tendon. Burn contractures, always Z-plasty. And for our high-stakes anatomy, femoral vessels get the sartorius, an irradiated axilla gets the latissimus dorsi, and a large lower eyelid defect absolutely demands a Mustarte flap. You should be able to rattle these off without a second thought.
Finally, Section 5, Top 10 Viva Pearls. This is our final high-yield sprint.
Let's break down the lower limb geographically. It's like a map. The upper tibia, that gets the gastrocnemius muscle flap. Move down to the middle tibia and it gets the soleus flap. But for the lower tibia, where there is very scarce local muscle, you're going to need an anterior lateral thigh or ALT free flap, or a reverse sural flap.
Now moving to the face for pearls 4 and 5. A complex nose defect demands the paramedian forehead flap, while the mandible structurally requires the fibula osteocutaneous free flap for rigid, bony reconstruction.
Rounding out our final pearls, pearl 6, the tongue pairs beautifully with the thin, pliable radial forearm free flap. Pearl 7, if you have a head and neck defect but microsurgery just isn't an option, you rely on the workhorse pectoralis major myocutaneous or PMMC flap. Pearl 8, sternal wounds post-CABG are literally saved by advancing the pectoralis major muscles bilaterally. And pearls 9 and 10? Well, that's just confirming that our pressure sore triad and our hand matrices remain absolute, undeniable gold standards in any clinical or exam setting.